All right. Hello to you, our listeners, the manipulated and the manipulators. Welcome to the OMM Research Podcast. The OMM Research Podcast is produced by DO-Touch.NET, a practice-based research network that focuses on osteopathic manipulative medicine research. DO-Touch.NET is based out of the A.T. Still Research Institute, located at A.T. Still University in Kirksville, Missouri. Please note that the views and opinions of the panelists in this podcast are personal to each panelist and do not reflect the views or opinions of A.T. Still University. And today, as always, we want to start off by introducing our panelists for this episode. So we'll start with Steve and Stacey, if you'd like to introduce yourself.
Hi, my name's Steve Stacey. I'm the Director of Osteopathic Education for the La Crosse Mayo Family Medicine Residency Program and Assistant Professor of Family Medicine at Mayo Clinic.
And thanks for being here with us today. And then we want to introduce Al.
Sure. Hi, my name's Al Amendolara. I'm a PGY1 in neurology at St. Luke's University Health Network in Bethlehem, Pennsylvania.
And thank you also, Al, for being here with us today. And so we have a couple exciting studies that we're going to be articles that we're going to be looking at today. And the first one we're going to be looking at is a pilot study that is brought to us by Al. And so, Al, I'm going to pass it off to you to introduce the study for us.
Sure. So this study is called Effects of a Single Osteopathic Manipulative Treatment on Intraocular Pressure Reduction, a pilot study. This is by King et al., and it was published in 2025, I think February of 2025, in the Journal of Osteopathic Medicine.
Can you give us a little background?
A little bit about this.
Yeah.
So a quick overview of the study. So they were looking at intraocular pressure, as specifically relating to ocular hypertension and glaucoma. So it's elevated in those conditions. And what they did is they started up a trial where they recruited patients at their facility that had elevated intraocular pressures or prior diagnosis of ocular hypertension or glaucoma. And they enrolled them and they performed some osteopathic manipulative treatments on them and then measured their intraocular pressure. They did this before the treatment and after the treatment. And I think at a 1 week, or they called it a 1 week follow-up. It was really 5 days. And what they found is a significant reduction in intraocular pressure post-treatment in the intervention group. However, they didn't find any between group differences. So this is a point that I'll talk about a little bit later. But overall, they concluded that the application of OMT showed some potential for the reduction of intraocular pressure in these patients with ocular hypertension or suspected glaucoma.
So what are your bullet point high points? So like what kind of jumped out at you as like the good things, quality things or neat things about this study?
Yeah, so there was one thing that jumped out at me that I really appreciated. It's something that we don't see all that often, and I'm always pleasantly surprised when I do see it. And that was that the authors were aware, I think, of their study's limitations, and they do a good job addressing them in the discussion. And I think they, in addition to just addressing them and saying that these are limitations, I think they very consciously stated their conclusions. They didn't overstate their conclusions. They acknowledged that this is a pilot study, that this isn't really clinical data being used to guide treatment, that it's as a baseline for future research. And I think they were pretty aware of the potential limitations of this study, the small sample size, the fact that there is some variability in intraocular pressure during the day, as well as within measurements. They also didn't have like a sham treatment. So they talk about a few of these things and they acknowledge them. And I think that's a really good thing that they did in this study.
And then on the flip
Yeah,
side of the
looking
coin, oh, sorry, go ahead, Dr. Stacey.
yeah, so even though they had this comparison with no treatment and there was no differences between the groups, yet still in the abstract, they came to the conclusion that the application of OMT shows potential benefit. And I'm just not sure what they're basing that off of when they went to the effort of getting a control and then didn't see any difference with the control. And this gets to one of my, boy, this is a rant you're probably going to hear a lot on this podcast, my
Okay.
rant
I
against pilot studies.
I'm going to agree with you here. I'll let you go on this rant because I think I know where it's going. But I agree with you here, and this is probably my biggest problem with this study. But you take it away because I suspect that I'm going to agree with everything you're about to say.
Yeah, so I see this a lot in osteopathic research where people throw the word pilot around in relation to their study as sort of an excuse to have a small, crappy study that was underpowered to really show anything. And that can be fine if you're using the initial data to generate an appropriate power calculation for then recruiting for the real study. But very few of these quote unquote pilot studies turn into actual research studies that can guide clinical practice. They end with the pilot study. And I don't know if these researchers are just hoping that by calling it a pilot study, somebody's going to publish this and then everybody's going to be like, oh, yeah, we know it wasn't clinical evidence, nod, nod, wink, wink, but we're still all going to say that it works. Or if they're just hoping somebody else is going to end up doing the real research. But we have enough pilot studies out there that need better, well-controlled, better powered studies that's really where a lot of this effort should be focused.
And Al, do you agree, disagree? Anything else you want to lay on?
I I do agree, and you said something interesting here. You mentioned the power analysis, and I think that's one of my. This is one of the things that I don't love about this. They do say that they did a power analysis. They state that their original power analysis established a sample size of 28 patients, which seems. I would like to see that power analysis. I'm not sure I buy that 28 patients is really a large enough sample size to find a meaningful difference. So it does make me question whether this was intended to be a pilot study or was a pilot study because they didn't hit their pre-specified power, even though that power was already very small. So I'm a little confused
Yeah,
about what they were planning with that to begin with. And I don't love, I don't know that there's a justification for any clinical trial having a power or having a sample size of 28 patients.
right. And also, and this is something that we see a lot in osteopathic research where there's very little connection drawn between the techniques chosen and the thing they're trying to
Right.
treat, where it's just sort of this general understanding that, hey, osteopathic medicine is good for everything and this is a thing, so let's go ahead and try it rather than really looking at initial principles and saying, okay, what is an external force applied to the body really meant to do at a physiologic level, and how am I drawing the connection between that and the process of intraocular pressure? And I just don't really buy the connection that they're trying to put together there. And so the a
I,
priori analysis
I
is that this
agree with you.
probably won't work.
I agree with you on a kind of a pathophysiological level, but I will give them credit for at least citing prior clinical research as a basis for this. I haven't dug into it too much, so I don't know that it's particularly convincing prior research, but they do make an attempt to at least justify that they're doing this because there's been prior research looking at this. I don't know that it addresses your
Yeah.
complaint completely, but I did want to throw that out there.
And not to put you on the spot saying you haven't really dug into the prior research, but for us non-osteopathically trained people listening to the podcast and myself who's on the panel, what kind of techniques were they using to treat this pressure and glaucoma of the eye? What were they claiming worked? How was this done?
So that I have a little bit of a problem with that. I think they fall into the trap of just broadly saying that they did some OMM. They list a variety of techniques. They say they did some soft tissue release, some myofascial release. They also mention osteopathic cranial manipulative medicine, and they go into a little bit more detail, listing some specific osteopathic cranial techniques. They also mention sacral rocking, but there's no real protocol laid out for what treatments they did. So we as readers are left to assume that it varied between patients. And again, I think it becomes very difficult to know if any one particular treatment had any effect, or even to link a possible effect to any of these treatments, because we're really shotgunning different different approaches at these
And this is
patients.
this is a common argument that comes back and forth in manual therapies research where you say, do we do protocolized OMM or do we do physician-directed OMM? And
Right.
there are very strong opinions on either side. And I come down on the side of it depends on the question you're trying to ask. If you're trying to ask, is protocolized OMM going to be effective in whatever situation, then you need to study protocolized OMM. If you're going to ask whether physician-directed OMM is helpful in a certain situation, then you need to use physician-directed OMM. And each of those things are going to have their own strengths and weakness in terms of the real-world applicability versus uh, the replicability of it in a research setting. And there are good arguments on both sides, and there's room for both in the research world. And in fact, a single study could potentially evaluate both things, right? Where one of the randomized arms
Mhm.
is protocolized OMM and another one is physician-directed OMM, and see if there's a difference.
Well, talking about differences, I do want to mention this because I know we mentioned it at the very beginning, and Dr. Stacy, you mentioned it with their conclusions, but their primary outcome of whether or not there was a difference between the sham or the no treatment group and the treatment group was non-significant. And what they're reporting as their positive outcome is essentially a within group difference. So there was
Right.
a reduction in intraocular pressure pre-treatment and post-treatment in the OMM group, but it was a fairly modest reduction, 1.6, which I think is very, very close to what I would consider within the margin of error of the tools they were using to measure intraocular pressure. And of course, within the variability, our eye pressure changes through the day. This is
Right.
a well studied phenomenon. And with these low sample sizes, it makes it really difficult for me to look at that and say, well, this was the one
Yeah.
significant finding. And, how robust is that? How replicable is that? How clinically relevant is that?
Right. Well, and we don't have a natural history progression, right? It would be like
Right.
saying we're comparing aloe vera to squirting orange juice on sunburns. We measured them both after 1 week, and we concluded that orange juice statistically significantly improves sunburns. But you don't have a comparison to natural history, which is it's gonna heal. You don't have to do
Right.
anything.
All right, so
Right.
I'm gonna pose to you, Al, as we kind of wrap up on this article and everything. So what would, if you were to pick one thing about the study, like for like next steps, what would you say like would be the next step for the study? Something to like focus on, maybe go back and try again. What would be your recommendation?
Really, I think this comes down to sample size here. All of the other complaints that we have are in some ways academic. You could chalk them up to differences in opinion, or you know, uh, there are discussions that we could have endlessly, but the core issue here is that the sample sizes are so low that I'm not sure you can gain any meaningful data. And honestly, I don't know how well this could direct a power analysis for a future study, because we still don't really know what the expectation is for what sort of difference are we actually looking for. And in that case, I would say there's better studies, better prior research out there that you could use as your foundation for power analysis, which I'm assuming that they did because they actually attempted a power analysis here.
Yeah.
Sure.
One thing I'd like to see in this study would be also verification that there is concealment to the person making the outcome assessment, that is different than the person providing the treatment, and also looking for concealment among patients and see if there's evidence of unmasking to see if they knew which treatment group they were assigned to. And where you have significant evidence of unmasking, this is more so typically in something with a subjective outcome, but really in any outcome, you do worry about if patients knew the treatment allocation, what effect is that going to have on the primary outcome?
Gotcha. All right. Well, as we are moving on to our next article, I also just want to stay here that we do have a video portion of this podcast that we record in addition to the audio. So if you are listening on your podcast platform and you would like to see our beautifully bearded faces as we are discussing these different articles, you can follow us or see these videos and these conversations that we're having on the DO-Touch.NET YouTube channel. That's DO-TOUCH.NET. We have our YouTube channel where we have the full podcast episodes posted with our, of course, the audio content and everything. And you can see these discussions as we're going forward. Apart from that, so we're going to move on to our second study here, brought to us by Stephen, which is looking at cervical spondylosis. That's a word that I'm not familiar
Yeah.
with.
So the title of the article is Efficacy Comparison of Osteopathic Muscle Energy Technique and Cervical Mobilization on Pain, Disability, and Proprioception in Cervical Spondylosis Patients. And I'm going to butcher the author's names because I don't know a word of Turkish. They're Buse Serese and Inki Yurksel. So my apologies to anybody, especially the authors. It was published August 4th, 2024 in the journal Medical Science Monitor. And their research question was, does adding osteopathic muscle energy technique or cervical mobilization to standard electrothermal therapy offer better improvements in pain, functional disability, and proprioception among patients with cervical spondylosis? And at the end of the study, they concluded that for their primary outcome, they really didn't see a difference between these therapies. However, they did in some of the secondary outcomes, including some amount of cervical proprioception. So if we dig into the methods a little bit, 96 adult patients diagnosed with cervical spondylosis were recruited from an outpatient PM&R clinic in Turkey. And
I'm
after
gonna cut
dropouts,
in right here
how'd you go?
because I no, it's okay. I'm just gonna cut in because not only for myself but for other people listening. What is cervical spondylosis?
So very simply, it is a finding on imaging that shows an abnormal positioning of one cervical spinal segment with relation to the other. And there can be a number of different reasons for that, sort of different ways that that can be categorized, but that's sort of the gist of it.
Gotcha. Thank you for the explanation. I just before we dove into it and we hear the word over and over, I thought we could just get a little bit like, hey, what is this? Because it's not like something common
Sure.
that I think a lot of us could just easily piece out. So continue. I
Yeah.
apologize.
So in this case, they needed to have cervical spondylosis and chronic neck pain. Adults aged 18 to 65. They found 96 patients, and 76 ended up completing the study after dropouts. Exclusion criteria included things like prior neck surgery, neurologic deficits, trauma, inflammatory disease, current PM&R treatments or PT, things like that. And so the intervention they were looking at was each group got electrothermal therapies, which included things like a TENS unit, heat applied to the area, and there was a protocol for that. And of these three groups, one got just the electrothermal therapy, another one got muscle energy technique, and then another one got cervical mobilization, which was a combination of different osteopathic techniques according to a protocol that they outlined. The outcomes were pain intensity as measured by a visual analog scale and functional disability assessed with the Copenhagen Neck Functional Disability Scale. And then they measured cervical proprioception in a variety of different directions. So all three groups showed improvements in pain. They didn't find really any differences between groups, which was their primary outcome. So in that sense, we would call this a negative trial. And then when they were looking at proprioception, they found that in extension joint position error, there was a statistically significant improvement, but for all other directions of neck movement, there was not a statistically significant difference, which they appropriately reported on without really making too much of it, as you can oftentimes find statistical significance in when you have a variety of secondary outcomes.
Mm-hmm. So, what are the high points the bullet pointed high points you want to point out to the listeners?
Yeah, so I think this is an interesting trial because really what it's doing is it's comparing um, something that really needs to be physician directed against something that could be more patient directed. Outside of the TENS unit, which is maybe a little bit more technologically intensive, a lot of the other stuff like applying heat to the area is something patients could easily do at home. And a lot of times what we see are manipulation trials um, that are compared to inactive controls. Um, Now, in this case, there really wasn't. They didn't try to conceal treatment allocation, and there wasn't really blinded assessment, and so that introduces some amount of bias. But as it was a negative study, it's hard to say then that the bias um, caused a positive study. So you could maybe think, was there a type 2 error, meaning a false negative? And that really, I would say, is not excluded by this study with the small numbers. They did say it was adequately powered for what they were looking for, but um, it wasn't powered to find small differences.
And then, what are the bullet pointed, negatives or limitations that you want to point out to the listeners?
Um, so a couple of the things that we mentioned, already about not really being able to blind it or really, exclude some of these other factors that could be leading to spurious results. I liked the fact that they were getting a little bit more granular rather than just saying broadly neck pain. They're trying to narrow down a certain condition and find a certain indication for that certain condition. And um, I applaud them on looking at it with that level of granularity. And for an OMM study, recruiting 96 people is actually pretty laudable. In research in general, 96 would not be considered a large study. I mean, if you imagine like a cardiology study that involved 96 patients, that's probably a phase 2 trial that is, that was deemed to be negative and abandoned. Uh, Versus in OMM studies, it would be, it's a decent number. So it would always be better to have more people so then that you could find smaller differences.
Sure. Al, is there anything that you want to add to the high points, high or low? Any points in general?
I agree. With some of those points, I like the fact that they have a study that is at least appropriately powered based on what their starting expectations were. I like that they include pictures of what they
Mm-hmm.
were doing,
Hmm.
and some descriptions of their treatments. I think this
Yeah.
is all very
So this was
uh,
the picture. Oops, that's not what I wanted
Yeah,
to
it is
do.
a well illustrated article.
yeah, I appreciate that. I think that helps with our visualization, and I also think it helps with replicability. If anyone were to redo this, it's nice to know and have a visual guide of exactly what they did, which is something that we don't always find.
So is the blue
Um,
pad they have in these pictures the thermal pad that they're talking about, or is this something else? I mean,
I'm
I
assuming so.
I have to assume it is, yeah.
okay.
I think my biggest complaint is, and maybe Dr. Stacy, you have more insight into this. It's not clear to me that their control. i- I don't know if this is my favorite control. So they use a thermal pad and these, kind of electrotherapy, these TENS stimulators. I'm not. I guess I don't know if that's my ideal negative control, or it's not really a negative control,
No,
right? We
it's
expect some.
definitely Yeah, it is an active control because these are things that are commonly done for neck pain, TENS
Right.
unit, applying heat. And and really most of us aren't thinking of comparing like, well, I was going to send my patient home with a TENS unit and a heat pad and OMM, or I was just going to send them home with a TENS unit and a heat pad. So probably
Right.
my biggest complaint, going back to your question, Corey, would really be this isn't necessarily a clinical question that we are asking, and yet they gave us the answer
Right.
to it anyway.
Sure. I mean, I
Well,
know
to
whenever my neck
me,
hurts, I like to go heat up a rice sock, and sit down
Oh,
with
for
it.
sure.
So,
well, this is essentially like a non-inferiority study, which I don't think we're at that point with some of these techniques to be
Yeah.
doing that sort of study design or that sort of question. We're not ready
Yeah.
to ask that right now, essentially, is my complaint with their control choice.
mhm.
Yeah, as OMM studies go, I would say this is among the stronger ones, just in terms of their rigor. But yeah,
Agree.
definitely some things that could still be improved on as people design future studies.
And building on that, the things that they can improve on in future studies and stuff. Where would you take this study for like a next step or anything? Would you?
Yeah, so this is something you're again going to hear me say often, but I'm a strong advocate for concealing allocation among patients and then looking for evidence of unmasking so that you can evaluate for whether the the knowledge of treatment allocation might have been a factor affecting their perception of
Will
improvement,
be
especially when,
subjective, right?
right, when you have a subjective outcome, especially, something like pain. And, in terms of what the control is, frankly, we don't have enough data about different types of controls and their relative merits. And this is frankly a fruitful area for research. If somebody wants to dig into that, when would it be appropriate to choose a waitlisted control or an active treatment comparator or sham therapy and different kinds of shams, right? Light touch sham, ultrasound sham, waving your hands over the patient, and which ones have the smallest clinical effect and the most believability for the patient. So an ideal sham would be something that has absolutely no effect other than the sort of ritual of care, but that patients are absolutely convinced was the active treatment. And that's one of the things that makes a placebo pill such a great thing and a natural fit as a control for medication therapy. But one could imagine that there would be such a thing for manual manipulation. We just haven't gathered the, I would say,
Mhm.
necessary data. But if you would include that rather than the active control, I think that would probably be more of the clinical situation we find ourselves in.
Gotcha.
Yeah.
Al, same question to you.
This is something that I think I complain a lot about with some of these studies. I have a real problem with their secondary outcomes. I I have to ask, why are we assuming that any of these treatments would impact, for example, this kind of proprioception or joint position error? I I don't know from a physiological basis. Like, I guess to begin with, I'm not necessarily, and maybe this is my own knowledge gap, but I'm not sure what we would expect the differences to be and how these are necessarily relevant to these patients clinically. And then what difference are we expecting to see with this and why? So we're doing these interventions and we're measuring this joint position error, but why? What does that show us clinically? Is this beneficial to patients? Is this answering any relevant question? And I struggle to see how their secondary outcomes are answering any of those questions. And I know there's an argument to be made for doing some exploratory work when you have these patients, you have the data and you have the tools to do this. And I certainly don't want to discourage people from doing exploratory research, but I think in the context of a clinical trial like this, I would say that I
Yeah.
would like to see more thought given to what your outcomes are, why you think there might be a change in those outcomes,
Why
and how
why you
we
thought
might
there
use
might be
information.
why you thought there might be fish there before you cast in the line?
Sure.
Right, and what kind of fish we're going to catch. Like, what do we do
Yeah.
with
I mean,
those
I
fish
can
when we
drop a
get
fishing
them?
line into a bathtub and then be surprised when nothing comes up, but
Right.
Well, on that, we are going to wrap up this episode today. We want to thank our panelists for being here for this episode. I think I neglected to introduce myself at the beginning of the episode, and I am Corey Lubring, and I am the Practice-Based Research Coordinator for DO-Touch.NET and the host of the OMM Research Podcast. I'll make sure to work that into my script for next episode so you all know who I am at the beginning of the episode rather than the end. If you are interested in more of what DO-Touch.NET is doing, you can check out our website, which is DO-Touch.NET. And you can check out research that we're doing there, become a member, get involved within the network. You can check us out on social media, on Facebook, on Instagram, and on LinkedIn, as well as Blue Sky. We do currently have a study going on where we're looking at recruiting clinicians on a retrospective chart review, looking at the treatment of anxiety in adolescents with OMT. So if you're interested in getting involved with that, check out our website and reach out to us if you want more information. Other than that, we will thank you all for listening, and thank you, Stephen and Al, for being here this week. And we'll talk to you all next time.